Hello, everyone. Welcome to this new episode of our Connect podcast. For those of you who still do not know us, we are a newborn association founded by the former Colonia Group to foster networking among physiology enthusiasts. Pathophysiology Stories is an idea that developed to rediscover the stories behind how the modern intensive care developed, thanks to the curiosity and passion for understanding the underlying mechanism of diseases. And how today we will talk a little bit less about history and more about a very still active pathophysiologic discussion. I'm Irene Steinberg, and I'm here today with my colleague Antonio Fioccola.
Hello, everyone, and welcome. It's a real pleasure to introduce today's episode dedicated to extracorporeal kidney support therapies titled Renal Support in the Intensive Care Unit. Should we wait or should we act? We have the great opportunity to interview one of the leading experts in this field, Professor Stefano Romagnoli. He is full professor of anesthesia and intensive care at the University of Florence, Director of the Department of Oncologic Anesthesia and Intensive Care at Careggi University Hospital, and Director of the Residency Program in Anesthesia and Intensive Care in Florence. Professor Romagnoli, welcome.
Welcome, everyone. Thank you, my good friend Antonio and Irene, for inviting me to talk about one of the most fascinating fields in critical care, that is renal replacement therapies or kidney replacement therapies. Thank you very much for inviting me.
Well, I'd like to accept these assist and to start this talk with the terminology KRT, CRRT, IHD. Which acronym should we be using on the word when we are about to initiate renal replacement therapy in critically ill patients in the ICU? Professor Romagnoli.
This is a good question. First of all, before going into some details about the acronyms, I want to tell you that it's my personal opinion that using different acronyms and terminology in general could be quite confusing. So I hope that in the near future, the scientific community will decide which should be the most appropriate terminology that we have to use when we discuss about these topics or when we publish about this topic. So, ART, kidney replacement therapy, or renal replacement therapy. The term kidney replacement therapy is growing up, is increasingly forward in recent high impact literature, but also in some guidelines. And it includes all the extracorporeal modalities, therapies for renal support. So it includes intermittent hemodialysis, continuous therapies, peritoneal dialysis. The shift may be from the current, the traditional terminology, renal replacement therapy, to kidney replacement therapy, might reflect a move toward a more anatomically precise and inclusive terminology. But we have to say that the classic terminology, renal replacement therapy, remains widely used in clinical practice, but also in scientific literature. Newer publications and expert reviews advocate for adoption of KRT, not RRT, just to mention one of the most important contributors in this field, Marlies Osterman. She commonly writes about kidney replacement therapy. So it will be important in the near future to harmonize terminology. But currently, both acronyms are accepted. So there is no the right and the wrong terminology in the clinical and in scientific community. Going into a little bit more details, so kidney replacement therapy and renal replacement therapy include all the modalities, so the intermittent, the continuous, the peritoneal, the hybrid. What is important is to distinguish the renal replacement or kidney replacement therapy into continuous. So now again, we have continuous kidney replacement therapy or continuous renal replacement therapy. That is hugely different from the intermittent hemodialysis and the hybrid techniques. So just to summarize, we can use both kidney or renal replacement therapy, but it's important to underline if we want to apply to a patient a continuous treatment, so a continuous renal replacement therapy or a continuous kidney replacement therapy or an intermittent hemodialysis or a peritoneal dialysis or an hybrid technique.
Thank you, Professor. I think these precisations are really important because, I mean, we need to know what we're talking about when we're talking about, for example, indication. So in your opinion, what are the absolute indication for starting, let me say, kidney replacement therapy, and which one are the considered relative indications?
Thank you for this very important question. As you said, we divide indications into two groups. The first one is the urgent or emergent indications. When we talk about urgent or emergent indications, everybody agrees. There's no discussion. When we have one of these clinical conditions, we start a continuous or an intermittent kidney or renal replacement therapy. Globally, urgent indications can be summarized as first, severe metabolic acidosis refractory to medical treatment. Second, pulmonary edema, again refractory to medical treatment. Third, uremic complications like pericarditis, encephalopathy, or bleeding. Fourth, severe hyperkalemia, again refractory to medical treatment. Fifth, intractable fluid overload coupled with organ dysfunction, and these could be linked to pulmonary edema, for example. But we have also the clinical conditions of severe fluid overload with organ dysfunction. And lastly, concomitant intoxication with a dialysable drug or toxins. Just to give some examples, we deal with in clinical practice lithium, salicylates, theophylline, methanol, valproate acid, metformin, ethylene glycol. What is useful to underline is that the absolute or urgent or emergent clinical indications for renal replacement therapy are not the most common indications in the ICU. These are part of our clinical activity, but the most common indications can be found in the relative indications that can be defined in general as all the indications for renal replacement therapy that are not included in the absolute urgent or emergent indications. And about relative indications, we can consider, and we have to consider, the progressive and or the persistency of acute kidney injury. Most important is severe non-kidney organ dysfunction that is due to and worsened by acute kidney injury. For example, a decrease in respiratory function, the decrease in liver function, the congestion and dysfunction of the gut, and so on. And finally, but closely related to the previous relative indications, a general worsening trajectory of physical illness. So in other words, when we consider that the benefits, and after maybe we will discuss about the timing to start, while we are observing our patient, we have to consider if the benefits of waiting are going toward negative consequences of still waiting. And the best moment to investigate and to understand the relative indications is during the ICU handover among colleagues and at the bedside. But when we have to consider non-kidney factors, we have to investigate patients' trajectory. For just to give an example, that in my mind is quite clear. I have a patient who is anuric after an emergency surgery, for example, abdominal aortic aneurysm rupture. And he has or she has developed abdominal hypertension. He or she is anuric, and she clearly has, or he clearly has a fluid overload. The new surgery with the positioning of the vacuum therapy is planned. In this case, it's better to wait for the completion of this kind of surgery, the treatment of abdominal hypertension, and we consider the patient worse to wait for it doesn't match an indication, even if in the list we have persistency of AKI, we have fluid accumulation, but in this case, the patient should wait for starting renal replacement therapy.
Thank you. So looking ahead to 2026, do you think there are some tools that might help us to decide when to initiate renal replacement therapy in a patient with a relative indication? Do you think there are any biomarkers that might help us here today or in the future?
Good. This is a question about how the clinician can decide when to start or not. The question is very important because we always have to keep in mind that renal replacement therapy is not it doesn't hurt to try technique. In other words, we know that by putting the patient under filter, help the clinicians to get a more rapid equilibration of acid-base status. They help to get an easier control of fluid balance and better control of solute clearance. They might help the clinician to apply immunomodulation, blood purification therapies, and it facilitates the administration of supportive measures like transfusions, nutrients, or medication. But at the same time, we also have to consider that putting a patient under a renal replacement therapy, we might expose the patient to higher risks of bleeding, or if you use, for example, heparin as an anticoagulation strategy, or we might expose the patient to acid-base imbalance, if we use, for example, regional citrate anticoagulation, we might underdose antibiotics. And we have also to consider that in most of the cases in our patients, acute kidney injury is related to sepsis and septic shock. So the loss of antibiotics might be determinant in the outcome. We might also lose some nutrients, for example, some vitamins, especially those belonging to the group B group vitamins, because are small and very easy to be eliminated in the effluent. The sieving coefficient is quite high for many vitamins B1, B6, for example. Then we can expose the patient to a higher probability to infection, complications, but also damage of the big vessel we put the catheter in. And so we expose the patient to hemodynamic instability. So going back to the decision where to start or not, renal replacement therapy, we have many studies and many patients, big studies, randomized controlled studies. The story of timing to start dates back to the Alliant trial published in JAMA in 2016. Then we have the Akiki trial in 2016 again. Then we have the Ideal ICU 2018, the START AKI 2020, the biggest one, and the Akiki 2 trial in 2021. I'll try to summarize the timing to start because these are quite different trials. But now we can say that a strategy that is based to watch and wait seems to be absolutely safe for a patient and more appropriate. And I want to quote a few words written by Marlies Osterman and collaborators in The Lancet 2025 about timing. They say, going back to the previous question, that urgent indications for renal replacement therapy include medically refractory hyperkalemia, metabolic acidosis, fluid overload with pulmonary edema, and uremic complications. Second, in clinical practice, these conditions are quite rare. Relative indications are more common, but defined with less precision, as we said before. The last sentence is very important. In the absence of urgent indications, randomized controlled trials from 2016 to 2020 support a watchful waiting approach. So, trying to summarize again and trying to be clear, we have to know our patients. We have to understand if we are moving from the benefits of waiting to a benefits of starting, depending on what we said before, the trajectory of the patients, the worsening of non-renal organ functions. What we have in our daily practice as a tool for investigating, for trying to understand, for giving the patient a better chance to get better. We have a quite old test, the standardized furosemide stress test. That is a test that interrogates the tubular cell function. It's a practical bedside tool to anticipate the risk for AKI progression, including the likelihood of patients requiring renal replacement therapy. The furosemide stress test consider the administration of a single dose of furosemide, 1 milligram per kilo for loop diuretic naive patients, or 1.5 for those who had prior loop diuretic exposure. We look at the urine output for 2 hours. After 2 hours, if the patient has a urine output of at least 200 in 2 hours, the probability to necessitate renal replacement therapy is quite low. But on the contrary, if the urine output is below 200 in 2 hours after the furosemide administration, the probability to put the patient under renal replacement therapy is very high. So if I have done a furosemide stress test and this is negative, it's very likely that I will start renal replacement therapy without further delay. Because, if we delay too much, we increase in morbidity and mortality due to the risk of untreated metabolic and derangements and fluid accumulation. But if we start too early, we increase the risk of renal replacement therapy associated complications. Let's never forget that based on the studies I've mentioned before, deferred initiation resulted in the utilization of RRT by about 40% on average. That means that 60% of patients did not receive RRT at all, just because they were in the late or deferral initiation arm of randomization. But never forget also that if we wait too much, and I invite you to take a quick look to the Akiki 2 trial, where they found that oliguria for more than 72 hours was associated with increased 60-day mortality and no difference in RRT 3 days. So watch and wait, absolutely appropriate. Let's consider all the factors involved in deciding where to start or not, but don't wait too much, because after 72 hours of anuria, mortality increases a lot. About biomarkers, what I can say is that we have at disposition different biomarkers. The older is probably the NGAL, neutrophic gelatinase associated lipocalin. Then we have TIM2, IGF, BP7. We have cystatin C. We have CCL40. They have demonstrated some predicted values for the need for CRT, but their clinical utility still remains limited and are now not routinely recommended to guide an initiation of CRT. I just want to exclude or separate from this list cystatin C, because cystatin C is not a very expensive biomarker that can be used in association or can replace in some patients creatinine, because the difference is that creatinine is very sensitive to muscle mass. So in sarcopenic patient, we might have, and we eventually have a decrease in creatinine. And in that case, is the estimated GFR is clearly not accurate and totally not well informative to the clinician. in patients with sarcopenia, cystatin C is much more informative about the estimated glomerular filtration rate. Probably in the near future, and we will see when they will be published the new KDIGO guidelines, combining biomarkers of kidney dysfunction and damage with illness severity scores may improve prediction, but again, current evidence does not support the use over conventional clinical judgment and established criteria. Biomarkers are part of renal research and will probably have a role in the future, but so far it's not part of a clinical practice, in part due to the fact that they are still quite expensive. A potentially new biomarker, this is my personal opinion, of course, could be the concentration and the global mass elimination of urinary ammonium. Urinary ammonium could be in the future a good biomarker of tubular function.
Thanks, Professor Romagnoli, for these precious clarifications about initiation of kidney replacement therapies. That's an open problem in a clinical daily routine. Now, let's move the focus to another open question when initiating a kidney replacement therapy: hemofiltration and hemoperfusion. There is growing interest in hemoabsorptive therapies in the literature. In which clinical scenarios is one approach preferred over another, and on what pathophysiological basis should this choice be made, in your opinion?
Thank you, Antonio, for the question. It's a very difficult question because we are talking about blood purification techniques. And now this is a very slippery floor. It's difficult to move on these kinds of techniques. The aim is for both filtration and perfusion, if we consider in the same question, because the aim of hemofiltration are a number of reasons, and we discussed in the previous question. But if we put hemofiltration and hemoperfusion in the same question, I think that we are talking about the possibility to manage to handle the immune system of the patients, and we are talking about blood purification. Cytokines are associated with prognosis in our patients. High concentration of pro-inflammatory cytokines, for example, interleukin-1, interleukin-6, TNF-alpha, are associated with worse outcome, but at the same time, also high concentration of immunodepressant cytokines like interleukin-10 might be associated with worse outcome. But at the same time, we have to consider that cytokines are also the way the immune system communicate and organizes the response to an infection. And as Marco Maggiorini wrote, I remember in one of his papers, let's remind us that nothing persists over millions of years if it does not offer a substantial evolutionary benefit. That means that handling inflammatory mediators might be useful for some patients, but might be harmful for others. So even if we are talking about this topic for many years, more than 30 years, because I remember in 1993, one of the most important research we ever had in our topics in critically ill medicine, Rinaldo Bellomo published a paper 33 years ago where he demonstrated that with CVVHD, he was able to remove cytokines in sepsis. But after 33 years, we are still discussing the most appropriate patient, the most appropriate timing, and the most appropriate device, because we have a number of different devices. We have devices that work with convection and diffusion, like CRRT or CKRT itself, the high volume hemofiltration, the high cutoff membranes. Then we have now the very, very famous hemoadsorption techniques or hemoperfusion techniques like polymyxin B, the CytoSorb tool, the Jaffron, LPS adsorber. But where is one of the main problems is that when we use one or more these techniques that can be sometimes also combined, associated, or even if not associated, they can work in both techniques. Just to give you an example, the Oxiris membrane, it works with the convection, with diffusion, but also with adsorption. The problem still is the fact that some good mediators, but also nutrients, but also antibiotics, but also vitamins, so good metabolites can be, not can be, are eliminated during this kind of treatment. And the last guidelines about the management of sepsis and septic shock, the Surviving Sepsis campaign, they say that for adults with sepsis and septic shock, they suggest against using polymyxin B hemoperfusion, but I have a comment on this. There is an insufficient evidence to make a recommendation on the use of other blood purification techniques. So what it means that probably hemoadsorption techniques and hemoperfusion techniques and techniques that use hemofiltration, hemodialysis might have a role in some patients. But still now there is a big uncertainty about that. My comment about the first statement of the recommendations from the Surviving Sepsis campaign regarding the against suggesting polymyxin B is that we now have a new trial. There are many trials published on polymyxin B hemoperfusion. The first one was a positive trial, the ELFAS trial, published in 2009 by Dina Cruz and collaborators. Then started new trials, like the Abdomix trials. There was a negative trials. Then the Eufrates trial, big Eufrates trial, that was negative. But after that, the meta-analysis and a post hoc analysis suggested the potential reduction of mortality in some patients with endotoxin activity assay between 0.9 and 0.6 and 0.9. So a new trial was planned and recently concluded, the Tigris trial. We do not have the trial published so far, so we must be very, very very, very careful in giving news, but we know that there is a press release given in August 2025, suggesting a potential benefit in terms of survival in patients with septic shock due to gram-negative bacteria with an endotoxin activity between 0.6 and 0.9. So how can we summarize the use of techniques for blood purification based on hemoadsorption or based on hemofiltration? That, to me, the available evidence does not justify the routine use of these techniques in clinical practice. These techniques must be investigated in well-designed clinical trials with the aim to identify the better timing and the better clinical condition, probably guided by one or more biomarkers. This is the reason why, at the moment, probably sepsis and septic shock due to gram-negative bacteria, with the possibility to test the leukocytes by using the endotoxin activity assay, could be one of the most easy way to have a sort of guidance in applying or not an hemoperfusion polymyxin B based approach. For all the others, so far, again, the guidelines do not suggest using the kind of techniques in patients with sepsis or septic shock. But guidelines can be interpreted sometimes if we are able to apply these techniques in a safe way. If we know the level of some cytokines, if we are able to be sure that applying one kind of blood purification technique can give to the patient higher probability to get better. Never forget that all these techniques are associated with a clearance of many different mediators, but most importantly, clearance of antibiotics. We are talking about patients with sepsis and septic shock. Antibiotics are the treatment. RT are supportive instruments that the clinicians use to steal time and to give more time to the antibiotics. Plasma concentration of antibiotics are of key importance and probably will be routinely used in every patient because our patients are very, very complex. Volume of distribution changes, the ability to clearance changes, to metabolize changes. So the possibility to have a clear monitoring of antibiotics concentration might be an important instrument, especially when we apply techniques that might lead to a higher clearance of some categories of antibiotics, because there are many variables also in this topic, because it depends on hydrosolubility, liposolubility, volume distribution, the relationship with the albumin, linked or not to albumin, and so on. So to conclude this part, we must be careful. We have dispositions in techniques. The guidelines do not support using them. if we use them, we have to guarantee safety to our patients. Safety means take care to antibiotics, especially antibiotics, but also phosphate, vitamins, and so on. So very, very a big attention when we handle the blood of our patients.
Thank you, Professor. From what you're saying, it appears that there are so many factors that we need to take into account when we're talking about kidney replacement therapy. And I think that knowing your devices and being able to understand the pathophysiology of your patient is fundamental in this field, because there are so many things that we need to consider. So taking this into account, what do you think are the current gaps in research that might help us to tailor more appropriately kidney replacement therapy? And what advice would you give to a young researcher in this field?
I think that one major gap the scientific community is investigating a lot is the immune system and the immune system monitoring over time. If we consider two elements, the first one is the major determinant of cause of acute kidney injury and kidney replacement therapy is sepsis. The second one is if we look at the definition of sepsis, we can identify the immune system as the major player. So the current gaps in research include the possibility to investigate over time, not just one at the beginning when we have the patient in our ICU at admittance, but over time, the characteristics of the immune system, and to work in parallel by giving immunosuppressors or immunostimulating drugs. The second, more related to kidney function, is related to the fact that when we talk about urine, we always talk about volume or flow, that is volume over time. But we never talk about quality, the characteristics of the urine. We know for many years, for example, that oliguria is a general concept based on volume over time. But oliguria might be a sort of physiological response of the kidney to a major perturbation. And in that case, we usually have oliguria with a very low sodium concentration because the kidney has reacted by keeping the sodium in the circulatory system. And the oliguria with high concentration of sodium is usually due to kidney damage and not due a kidney response to a major perturbation. So what we can do in the future, and this is now a gap in research, is looking at the urine characteristics, physicochemical characteristics, and not only in terms of milliliters per hour or milliliters per kilo per hour. That's all.
Thanks, Professor. I'd like to bring you one last question, mainly based on your clinical experience and personal feelings. Among the indications we have discussed today, which one do you believe derives the greatest prognostic benefit from the early initiation of renal replacement therapy?
Early initiation can be benefit or not. Because early indication might include those patients who recover renal function without renal replacement therapy, and then we expose the patient to the possible damages due to renal replacement therapy. But early indication might help the patients to avoid the involvement of other organs other than the kidneys. So my answer is a patient that might benefit not from early, from a timely indication. Timely means that you are starting at the appropriate moment, is mostly related to fluid accumulation or fluid overload and non-renal organ dysfunction. But at the same time, the sensitivity of the clinician in terms of having the ability to predict the probability of kidney recovery depending on a number of factors. Fever, yes or not, white blood cells, hypotension, hypoperfusion, norepinephrine going up, going down, vasopressin, angiotensin II, the drainage of the abscess, the treatment of the abdominal cause, the improving in infectious lung disease, and so on. So to summarize, the answer is when I see fluid accumulation, fluid overload, and an initial starting of non-renal organ dysfunction, that's the moment to try to understand if the patient might benefit of starting a renal replacement therapy.
Thank you, Professor. So, coming to the end of our podcast, I would like to thank you both, Professor Romagnoli and my co-host, Antonio Fioccola, for this really interesting talk. And just to remind our listener, the previous episode of Pathophysiology Stories are available on Spotify and YouTube. And you can follow Connect activities on the website of the association, or you can follow us on social media. We have Instagram, LinkedIn, and Facebook accounts, so that you might get in touch with the association if you want, or just follow what we're doing. So thank you so much to both of you. It was really, really interesting. And I guess we will hear each other at the next Connect podcast. Goodbye.
Bye, Irene. Thank you.
Goodbye. Thank you for inviting me to talk about this topic.